Varsha Ummareddy. She will be speaking on partial modified Knapps to the rescue of the congenital third nerve palsy.
Good evening everyone. I'm Dr. Varsha and I'm going to speak about congenital third nerve palsy, which was managed by partial modified Knapps. So as we all know, cranial nerve 3 palsies in children are often congenital and attributed to developmental anomalies or intrauterine or birth trauma, and the presenting features typically include unilateral ptosis, ophthalmoplegia and pupil involvement. Frequency of aberrant regeneration signs seen in these cases such as pseudo-von-Graffe, inverse Duane sign, pseudo-Arrayal-Robertson pupil and adduction on attempted up or down gaze suggests that majority of the lesions occur along the peripheral nerve. However, central lesions have also been reported. And the differential diagnosis encompass monocular elevation deficit, acquired third nerve palsy, Duane's retraction syndrome, congenital Horner's syndrome, chronic progressive external ophthalmoplegia and congenital fibrosis of extraocular muscles. My purpose is to present the surgical outcome of partial modified Knapps surgery in a case of congenital third nerve palsy. So my patient here is an 11-year-old female from Telangana who had the chief complaints of drooping of left eye upper lid since birth and also inability to move left eye since 3 years. She doesn't complain of any history of trauma to the left eye nor any other ocular symptoms or previous ocular surgeries. There was no significant birth history, family history and medical history. Personal history was normal. General examination was nil significant. On inspection, she had chin and brow elevation, and facial symmetry was lost due to left eye ptosis. Ocular symmetry was lost due to left eye ptosis and left eye exo and hypotropia. Anterior segment examination of the right eye was within normal limits and left eye showed ptosis and the pupil was round regular and reacting to light. Post-dilated examination was within normal limits in both eyes. Coming to the orthoptic evaluation, left eye showed 15-degree exo and hypotropia, and on alternate cover test, left eye moves in and up to take fixation, right eye moves down and out to take fixation. Prism bar cover test, a 30 PD prism, base in prism and 25 PD base up prism in left eye was kept to neutralize. Extraocular movement showed major limitation in elevation of left eye and also slight limitation in adduction. This is the 9-gaze picture. Sensory evaluation showed right dominance. And coming to the ptosis evaluation, palpebral fissure height was reduced and also there was poor Bell's phenomenon in left eye. Cranial nerve examination, all the cranial nerve was intact except for the cranial nerve 3 where there was elevation deficit, adduction deficit and poor LPS action. Both eye vision was 6/6, color vision both eye 17/17, brightness right eye more than left eye and fields both eye normal by confrontation. There was signs of aberrant regeneration, which is the inverse Duane sign seen in this case, where there is increased palpebral fissure height on adduction. FDT was negative. Management was left eye 5 mm inferior rectus recession and also left eye partial modified Knapps procedure was done where left eye complete splitting of LR muscle was done. The lower half of the LR muscle 9 mm precision was done and the upper half was transposed to the SR muscle and augmented with Foster's augmentation suture. The post-op, there was significant improvement in the orthotropia and the pseudotosis components was reduced because of the orthotropia achieved. Also, we have taken pictures of the post-op 1 month and there was improvement in the compensatory head posture as well. So for ptosis management, we have given crutch glasses and the patient was advised to follow up. So basically Knapps or modified Knapps is done for monocular elevation deficit and it involves the horizontal rectus muscle being transposed to the SR muscle. But here we have tried it for congenital third nerve palsy and we have achieved orthotropia
wrap up.
and also remove the
Time is
pseudotosis.
over.
Yes, ma'am.
Move directly to the conclusion slide.
Patient has shown optimal functional outcome following the surgical procedure as tailored to the patient's magnitude of deviation and deficit. Thank you.
I have a query. You say that it is congenital third nerve palsy, but you also mentioned aberrant regeneration, right?
Yes, ma'am.
But what do you think is the plan of management in a case of aberrant regeneration? What is the literature about aberrant regeneration?
Ma'am, actually, the other eye can be operated for left eye LR recession,
left
ma'am.
eye LR
But the patient, she's a young child. There's already a stigma of getting operated for the abnormal eye. So,
what was your observation about the post-operatively palpable apertures? You said that the HP improvement that was apparent also. But what was your observation about the palpable apertures? Because that is the only limitation when you operate a congenital a palsy case with aberrant regeneration. What was your observation about the palpable aperture in the eye?
ma'am, palpebral aperture actually because of the because of the elimination of the pseudotosis, because it's due to hypertropia, because of the orthotropia now, the palpebral aperture height is increased now, but not full ptosis correction was achieved because of the aberrant regeneration also. So we have given crutch glasses for now. The patient is being followed up now.